So yeah, it's my great pleasure to welcome Professor Rob Howard from University College London today. Rob is an old age psychiatrist with an long-standing interest in depression and also in anxiety and dementia. And yeah, he will be talking today to us. And just very briefly again, talking etiquette. So please keep your microphone switched off during the talk and also keep your video switched off during the talk. If you have questions, use the chat box and you can write your questions in the chat. Or if you want to ask a question in person, maybe switch on the video and then switch on your microphone, and then you can ask your question in person. If you didn't want to ask your question in person or in the chat, you can also email us. We put at the end of the talk again our email address, and we can forward the question then to Rob if you want it answered. Yeah, it's my great pleasure to have Rob here with us today. And so he's talking to us about treating depression in dementia. And I stop sharing, and over to you, Rob.
Okay, so first of all, I've got to try and work out how to share my screen. Sorry. Entire screen.
Can you see that? Yeah.
All I can see is you, really, Michael. That's the problem. Oh dear.
You don't have any controls underneath it, no.
Ah, here we are. Good.
Nice.
Okay. Well, good afternoon, everybody. Thank you so much for inviting me to speak to you. For those of you in Norfolk, I should just basically declare an interest, which is that I live for half the week in Fakenham, and my wife and I just fell in love with Norfolk about 30 years ago, and spend as much time up there as we can. So I envy all of you who can work there too. So I want to talk about the treatment of depression and Alzheimer's disease, and I want to particularly talk about a trial we've just completed. I hope I've actually picked up the right slide set in the panic just now, but let's see how we go. So depression is an enormous problem in people with Alzheimer's disease. So about half of people with Alzheimer's disease experience depressive symptoms, and at any one time about 20% of them would satisfy diagnostic criteria for major depression. And there's no doubt that having depression reduces quality of life for people with dementia. It's also absolutely terrible for their family caregiver. So as if having dementia wasn't bad enough, having depression as well really does impact on patients. And you know, I see some families where the patient with dementia is depressed, and it's easy for the whole family to get sucked into a terrible kind of swamp of negativity and nihilism. It's a really horrible situation. And we know that depression in dementia increases disability, cognitive and functional disability. It increases mortality. So people with dementia, also depressed, are more likely to die more quickly. It increases the risks of care home transfer, and it contributes, as I've already said, enormously to the burden that carers feel. And if you work in mental health services, depression is something that we're used to being able to treat. We know we can improve depression with antidepressants and with psychological therapies. Unfortunately, when we use antidepressants in the treatment of depression in Alzheimer's disease, what the trials have suggested is that actually antidepressants are no better than placebo in improving depression symptoms. So I apologize to people who aren't used to looking at these kind of forest plots, but what this figure does is it summarizes the better quality clinical trials that have compared an antidepressant with placebo in people with dementia, also depressed. And if you look at the kind of figure on the right hand side, you should see a line that runs down the middle, going through 1, and you should see a number of lines with a blue square in them, and each of those lines indicates the spread, the 95% confidence intervals of the spread of the outcome in a clinical trial. And for a clinical trial to have shown a benefit for the antidepressant, all of the black line on either side of those blue squares should be on the right hand side of 1. So if you look at the top of those, you can see a blue box with quite narrow 95% confidence intervals, and that was Shubi Banerjee's HTA-SAD trial, which was the largest and perhaps best conducted of these trials. And what you can see there was there's absolutely no difference between drug and placebo. And that trial very much kind of has skewed the distribution that we get when we do a meta-analysis on the rest of the results. And if you look down towards the bottom of this figure, you can see a test for overall effect, and the p-value there of 0.06, so just misses the 0.05 that we would want for significance. So, I mean, the bad news from this slide is that we can't really give an antidepressant to someone with dementia who's also got depression and confidently tell them and their families that we know there's evidence that drugs are better than placebo. But I'll talk a little bit about this, how the story is a bit more complicated than just that. And if we do the same exercise for psychological therapies, now just rather confusingly, the forest plot here is the other way around from the one you've just seen, so that actually we want to look at things that are on the left to show favouring treatment. And again, this reviews the better quality trials that have taken place. And what I think you should be able to see is that there's again, the overall effect, it has a significant p-value that indicates significance. So we can say that psychological therapies are better than placebo. They only have a fairly weak treatment effect size. Now, before we jump to the conclusion that that means they're better than antidepressants, I would just point out that clinical trials of psychological therapies are much more vulnerable to biases and unblinding. So it's very easy to give somebody an antidepressant or a placebo that look identical and to maintain the blind in the trial. It's much more complicated to try and do the same thing with the psychological therapy, because obviously the person who receives the therapy can't be blinded to the fact that they've had a psychological therapy as opposed to the placebo intervention. So even though this meta-analysis is more positive than the one that we saw just now for antidepressants, do bear in mind that this is probably subject to much more damaging bias. But what I want you to really take away from these last two slides is that we don't really have convincingly great treatments for depression in dementia, and that's a problem. And it's also a great shame when we're used to getting depression better in people who don't have dementia. So about 6 or 7 years ago, an American group who work at Cornell in New York published the results of some studies where they'd used what they call problem adaptation therapy to treat symptoms of depression. And they had looked at people who were not only had depression, but they also had cognitive impairments. So these weren't people who had a primary diagnosis of dementia. They're people who they were seeing in their depression clinic, some of whom had sort of mild cognitive difficulties. And so this is a result of a trial that they conducted. So it's a short trial, a 12-week trial, where they gave problem adaptation therapy as opposed to a kind of a control, sort of attentional control therapy. And what the graph shows is a reduction in symptoms of depression in the people who got the control with the grey line, and the people who got the path intervention, which is the dark blue line. And you can see the people who got the path intervention over the 12 weeks of the study showed a greater improvement in their depression symptoms, with quite a large effect size of 0.6. And they set a level for remission for depression, and what they showed was that 38% of people who got the path intervention had shown a remission in their symptoms, as opposed to only 15% who got the control intervention. So that looked like a very impressive result, but it's only in a small number of people, and it's a very, very short trial. Now the Department of Health had a kind of HTA trial competition 7 or 8 years ago, because they thought that problem adaptation therapy looked very positive for treatment of depression and dementia, and they wanted people to apply for a grant to adapt that therapy to be used in the NHS. And a group that I work with was successful in getting that grant. And we began, before we did the trial, by adapting path so that it'd be suitable for people with mild to moderate Alzheimer's disease and depression, because the people who'd been in the previous American studies didn't have dementia, certainly didn't have Alzheimer's disease. And so we did a year of preparatory work focused around sort of qualitative interviews with people who had dementia and depression and their families. And these were the themes that emerged from that work, that both the patients and their family members felt a sense of isolation and role loss following diagnosis, that the patients in particular had feelings of being a burden and being misunderstood by their family members and others around them, that often quite difficult to manage interpersonal tensions would arise between the patient with dementia and family members. And there were often strongly diverging views amongst the patients and their carers about the capabilities that the patient still had. And both patients and carers found the changeability in their abilities and mood very difficult to deal with. So based on these themes, we were able to design a version of problem adaptation therapy that addressed these areas. And we conducted a trial, and it was called the Pathfinder trial. You see the full title, Problem Adaptation Therapy for Individuals with Mild to Moderate Dementia and Depression. And we recruited 336 people who had Alzheimer's disease, although we allowed people who had mixed Alzheimer's and vascular dementia to come into study. They had to have a mini mental state score of 10 or greater. So we were looking at people with mild and moderate dementia. They had to score at least 8 on a scale called the Cornell scale for depression in dementia. And they also had to have an identified family carer or some other person who could carry out that role, who saw them for at least an hour, at least 3 times a week, and spent such a time with the patient, who could act as a co-therapist during the trial. To get into the trial, it was very important that you hadn't started or changed an antidepressant in the 4 weeks before entering the trial. We couldn't take people into the trial who had active suicidal plans or intent. And we recruited from 24 sites in the NHS across the UK. And this just shows the sites, and I would point out that Norfolk, where's Norfolk and Suffolk? It's somewhere on here. Yeah, Norfolk and Suffolk, you are sort of this is near the top, where you were sort of solid recruiters to the trial, and we thank you for that. This was a really hard trial to do, and we started recruitment at the end of 2019, and you can imagine the impact that COVID had on our ability to recruit, to deliver therapy, and administer the outcome measures. So as a consequence of COVID, we made the whole trial remote. So the therapy delivery and the collection of the outcome measures was all done by telephone or over video conferencing. And it worked actually a lot better than I would have imagined. I think everybody had to get used to doing a lot of things differently during COVID, and it was really impressive to see the way people with dementia and their families were able to manage to use the technology. So I've known the results of the trial for about 4 or 5 weeks, so I'm just going to quickly just show you what we found. I guess the purpose of this trial is just to show you how people flowed through the trial, and to indicate that out of the people that we were randomized and allocated treatment, we had pretty good retention of people through the 12-month follow-up of the study. This tells us something about what the people were like who came into the trial. So the mean age was 77, and 39% of people were male. You can see, unfortunately, we didn't get as many people from ethnic minorities into the trial as we'd hoped to, and despite picking sites in areas with very high ethnic minority populations. So I think this is a huge problem for trials conducted in the NHS. We all try to recruit people from these kind of hard to reach minority populations, but we're not very good at getting them into studies, and it's a challenge. We tried hard in this trial, and we didn't really do very well in recruiting a kind of a representative sample of people in terms of ethnicity. And yeah, this is a very boring slide, and I show this just because these are the slides that I showed to the investigators in the trial on Monday when I showed them the results. And it was really just to show them, if you look at the top, so the primary outcome of the trial was the change in the Cornell scale in depression and dementia at 6 months. So people came into this study, they were given up to 8 sessions of the therapy in the first 12 weeks of the study. And then we followed them up at 6 months and 12 months. And we made the primary outcome, the change in the Cornell scale, at 6 months, because we wanted to show that we hadn't just affected a kind of short-term immediate change in people, but that by giving them the tools that the PATH therapy provided, they'd been able to work with the new stat so that any recovery in depression at 3 months was maintained to 6 months. But it'll, as you'll see, that turned out to be quite a kind of optimistic ambition. But I show you this slide because this shows the sort of data completeness of the various outcomes. And if you look at the top line, you can see that 6 months, which was the primary outcome, we had 80.4%. We had primary outcome data on 80.4% of people who've been randomized. And one of the markers of quality of a trial is that you get at least 80% primary outcome data. So I was very relieved to see that we'd done that with this trial, because again, as you can imagine, during COVID, it became quite difficult sometimes to collect data. Now, you can summarize every clinical trial by a single figure, single graph, and this is the graph from the Pathfinder trial, because this is the primary outcome measure, the Cornell scale for depression in dementia, over the 12 months of the trial. And if you look on the y-axis at the side, that shows the the score on the Cornell scale for depression in dementia. And a score of greater than 10 indicates a severity of depression which is equivalent to a major depressive episode. So what I hope you can see is that at the beginning of the trial, the average score was about 13 points on that scale. And if we look at the primary outcome, which is at 6 months, is randomization, and if you look down the bottom, you can see the difference between people who got therapy and people who got treatment as usual. And that difference was minus 0.58 of a point on the Cornell scale. And unfortunately, the confidence intervals cross 1. So there wasn't a statistically significant difference between the PATH intervention and treatment as usual at the primary outcome measure of 6 months, which is a disappointing result, because nobody enjoys conducting negative trials. And if we look at 12 months, we can see that even though there was perhaps a greater separation between the people who got treatment as usual and people who got the PATH intervention, again, you can see down at the bottom, the 95% confidence intervals go through 1. So that's not a statistically significant difference. Even though, of course, at every point in the study, from 3 months onwards, the people who got PATH are scoring lower than the people who got treatment as usual. It just hadn't reached significance. But if we look at the 3-month point, so remember, these were people who'd had 8 sessions of therapy in the first 12 weeks. And then, so the 3-month assessment is really the sort of post-therapy assessment. That actually there was a difference of nearly 1.4 points with the advantage to people who'd had the therapy. And as you can see, that was significant at a significant difference at sort of accepted levels of statistical significance. So what we've shown is that this therapy, so it was a brief therapy over 12 weeks, that it actually produced a small but statistically significant improvement in depression ratings. But unfortunately, at 6 months and 12 months follow-up, even though the people who'd had the intervention had lower scores on their depression rating, the difference between those and people who had treatment as usual was not statistically significant. And when we looked at a number of sort of exploratory analyses to try and see could we explain why the therapy hadn't persisted, and so for example, you might expect that the people who had more severe dementia would have found it more difficult to kind of work with the therapy and to carry forward the principles that they'd learned in those 8 sessions. Well, essentially what we found was whether your mini mental state was 20 or above, or between 10 and 20, made no difference to how you got on with the therapy. So we can't blame the negative result on the fact that we looked at people with more serious dementia than had been looked at in previous studies. And this, I apologize, this is a very, very busy study, and a very busy slide. And what this slide shows is all the outcomes that we looked at in the trial at the various time points, 3 months, 6 months, and 12 months. I just want you to look, first of all, at the Cornell scale for depression and dementia. So if you look at the top, you can see at 3 months, we've got this significant result because the 95% confidence intervals are on the left-hand side of the dotted line, even though, as you can see, at 6 months and 12 months, they're not. But I want you to look at the EQ5D. This is a measure of quality of life. And if you look at 3 months, what you can see is that there's actually a significant advantage in terms of quality of life at 3 months for the intervention compared with treatment as usual. So not only did we see that 3-month benefit on the Cornell scale, we also saw at 3 months a statistically significant improvement in quality of life. So that's kind of encouraging, isn't it? That not just did people show an advantage in terms of their depression rating, they also had a better quality of life that went along with that, but only at 3 months. And there's nothing else that was significantly better with treatment at any of the other treatment points or on any of the other outcome measures. And I mean, that seems like a rather miserable result, you know, just a flicker of something at 3 months and nothing at 6 or 12. But I just show you this slide. So this is a slide from the HTA-SAD trial, which looked at antidepressants versus placebo. So it looked at sertraline and mirtazapine versus placebo. And you know, they ended up with a graph that actually looks very much like the graph that we had. So remember, I showed you that the average Cornell scale score at entry in our trial was 13. Well, so it was in the HTA-SAD trial. So I think what that shows you a couple of things. It shows you, first of all, that the people who are in our trial are very comparable to the people who were in the HTA-SAD trial, who are people who are being treated with antidepressants. So it'd be wrong to think that our patients were a more mildly depressed group just because they were being given a psychological therapy. But if you look at 13 weeks or kind of 3 months, there's absolutely no difference in this trial between placebo and the antidepressants. So at least our problem adaptation therapy intervention has shown superiority over antidepressants in producing that effect at 3 months. But remember what I said earlier about the risks of bias in psychological therapy trials. You know, I think it's probably important to bear that in mind too. But I guess our trial isn't, I mean, the results shouldn't just be viewed with nihilism in the way that the HTA-SAD trial perhaps was. So I'm very interested in trying to sort of improve the treatment of depression and dementia. And I think what we've shown with our trial is that 8 sessions of problem adaptation therapy over 12 weeks isn't sufficient to significantly improve depression at 6 months. And, you know, looking back on it, I think we were probably too optimistic to think we could make a difference that would persist. And if I was to do the trial again, I think I would probably continue the therapy all the way through the first 6 months of the trial. I mean, after all, we wouldn't treat people with an antidepressant drug for 12 weeks and then stop it and then expect people to be better at 6 months. So maybe we should have the same attitude to therapies. But the improvements that I've shown you in the Cornell scale for depression and the quality of life scale at 3 months do indicate a small immediate efficacy of the therapy. So the therapy was doing something. There's definitely an efficacy signal. And I guess the question is, what would happen if we persisted with it, you know, and kept the therapy going for longer? Would that efficacy have persisted as well to 6 months? I think that's an unanswered question. We've also shown that the path intervention is acceptable and feasible to deliver. I mean, the feedback we got from the centres who were involved in the study was all very positive, and you know, the patients and families were very enthusiastic and enjoyed being part of the therapy and found it easy to use over the telephone and over video conferencing. And you know, the challenge of doing a trial during COVID was enormous. And I think if you can show that something like this works even when COVID's going on, that's a very good sign. And just to return then to antidepressants being no better than placebo, if you remember the slide that I showed, I'll just go back to it, this one. I think it's important to say in this trial, so this was the antidepressant trial where drugs are no better than placebo, actually didn't really matter whether you got drug or placebo. Everybody got quite a lot better in this trial. And That may have been because of a placebo effect associated with being prescribed an antidepressant. But maybe that's not such a bad thing. And we need to be very careful when we dismiss something as being no better than placebo, because it may be a lot better than just doing nothing. So there may be some benefit to giving an antidepressant in this situation, even if most of that benefit is coming from a placebo effect. As far as the patients and their families are concerned, they're feeling better and getting better. So I would like to go back to the HTA and say to them that depression in dementia is such an important problem. It's a really hard problem to fix and get better. And we probably need a more sophisticated and intensive trial than the one I've just shown you. And what we're working on now is plans for a new trial in which we will test the effects of combining antidepressants and an extended sort of continuous intervention based on problem adaptation to see whether that is more effective at 6 months than either antidepressants alone or the shorter therapy that I've just shown you. So thank you for your attention, and I will stop sharing and happy to answer questions.